The way we tier our structure here at Regenerative Performance is I've got an extremity price, and then we have a lumbosacral price for injections because there's increased risks and we have imaging that we're going to use for that. And then there's cervical, again, due to increased risks associated with those procedures. Hey everybody, welcome back to another episode of Daily Doc Talk. I'm your host, Dr. Drew Timmermans. One question that I get from patients frequently, and one that I had on my Ask Me Anything Mondays on Instagram, is are we able to treat more than one area when we're doing things like Prolotherapy, PRP, or stem cell therapy? Or does the treating more than one area take away from the effects that we could have at one area? And so what I'm going to say to that is this: we don't have really any research data on this. There are no current studies out there that have taken basically groups of people and subjected them to just getting one of their painful areas treated or getting two of their painful areas treated, having placebo controls for both of those groups, and then looking at what actually happens between those to see if there is a difference between the healing potential from treating one joint versus two joints versus three joints or anything like that. And so what I will frame up here next is just going to be my personal philosophy based on what I've seen clinically, based on discussions with other providers, but also based on some different financial considerations for the patient. So I'm actually going to start with that last one first, financial consideration. So there are some clinics, and each clinic is going to operate how they want to operate, and I'm going to let you know how I operate personally here at Regenerative Performance. So if someone comes in and they have a knee joint problem and a low back problem, and both of those are connected, I personally don't charge the cost of two different joint injections. The way we tier our structure here at Regenerative Performance is I've got an extremity price, and then we have a lumbosacral price for injections because there's increased risks and we have imaging that we're going to use for that. And then there's cervical, again, due to increased risks associated with those procedures and increased training that's required, increased precision, and understanding what to do if a complication occurs there, because that's different than the low back, different than a knee joint. So, for example, if you come in and your low back is hurting you, it's one price. If your low back and your knee are both bothering you, it's still the same price. I don't change. And the reason why is because for me, it has never resonated with me to say, look, you've got a knee joint problem, and I think that your low back is contributing to that, so I need to charge you for both the knee and the low back separately in order for you to get the best outcome. How I'd rather approach it is, look, you've got both these things going on. I think we need to treat both of them. I can't talk today. Treat both of them, and that is going to be the same cost as if we were going to treat just the low back, for example. And so that's the first aspect of it. The second aspect is the number of joints that I've seen treated personally that we've done here is about 3 to 4. There's only a few times where I've had to treat 4 joints, and usually those are when patients are coming in for a stem cell procedure. They're coming in, they want to have a procedure done, they only want to have to do it once. Now, there is some research at least showing that we need a minimum quantity of either stem cells or platelets, for example, in each area that we're treating. And so if someone comes into my office and we're going to treat 3 joints, it's not like I take the same amount of stem cells and just split it between 3 joints. It's not like I take the same amount of PRP and split it between 3 joints. We need to get additional stem cells or additional PRP in order to actually compensate for the additional joints that we're getting. And so here we're at least making sure that we standardize the amount of platelets or the amount of stem cells that are going into each area. We're not just spreading it thin. So then the question really becomes, well, what about the healing capabilities of the body? Well, again, we don't have research to show that. However, I haven't personally noticed a trend towards a reduction, a significant reduction in outcomes when we do two joints versus one joint versus 3 joints. And so now I think personally it also depends on the severity of what's going on. If a patient has grade 4 osteoarthritis in both knees, but they also have a shoulder and an ankle thing going on, and the primary concern is the grade 4, which is the most severe form of osteoarthritis, and they are trying to avoid surgery, I'd rather stack the deck and just treat the osteoarthritis than to do both knees, the shoulder, and the ankle, because again, we don't know what's going to happen. That could reduce the potential healing of the knees. And so it's always going to be a case-by-case, individual basis. However, I don't think that it always has to be, you can only treat one thing at a time in order for there to be improvement, in order to see results. You can definitely treat more than one area. And at this point, as long as we are factoring in the additional solution that we're needing, the additional platelets, the additional stem cells, then it doesn't seem like we are hugely impacting outcomes and greatly increasing the number of treatments required for full resolution. All right, everyone. Hope you enjoyed this one. Take care.